Clinical Judgment, Week 6. This week we have a client who's a 25-year-old female. She comes into the walk-in clinic and is reporting severe abdominal pain. So as we look at her assessment findings, we find that she has a 2-day history of abdominal pain and she's rating it a 7 out of 10. Her heart rate is 110 beats per minute. It's regular. Blood pressure is 108/60. She does have nausea, but there's no vomiting. There's no vaginal bleeding. And remember, when we have women who are of childbearing age, in other words, they are menstruating, we have to determine the last menstrual period, and hers ended 3 days ago. She currently has a temperature of 100.6. Her respiratory rate is 20. Lungs are clear to auscultation. She reports having unprotected sexual intercourse with 2 different partners. Her abdomen is tender to palpation. The vaginal exam does show purulent exudate coming from the cervix. And her bowel sounds are active ×4. So look at these assessment findings and determine what is relevant or most important at this time. I'll give you a couple of minutes.
Over the last 9 starts, he's been really good. A 3.31 ERA, and he's got a 6.2 lead here in the fifth. And another strikeout. That's 5 of them today for the right-hander.
Okay, so these are the ones that I picked out. Does not mean that those are the only ones. It's just what I picked out when I was actually completing this assignment. So now we need to look at potential causes of these different cues because we need to try and figure out what might be going on with this client. What do these things mean? Well, the 2-day history of abdominal pain, maybe she has appendicitis. Could be a bowel blockage or just some gastroenteritis. Remember, she does have some nausea. Maybe it would be menstrual cramps, but we do know that her LMP was 3 days ago. There are quite a few other things that the abdominal pain could be attributable to. Endometriosis, for example. But let's move on. Nausea without vomiting. We do know that pregnancy can cause nausea. We see that a lot. Uh, Sometimes just some different odors can cause nausea. Gastroenteritis, the PMS symptoms, but again, her last menstrual period was 3 days ago, so that's probably not it. Sometimes it may be medications, sometimes it may be a food that we eat, etc. No vaginal bleeding. Well, there's not too many causes for that. It may be prior to menarche, but she's 25 and we do know that she just had her last menstrual period. It could be menopause, but again, she's 25 and we don't normally see menopause unless it's by surgical means at that young age. Pregnancy is the biggest one. Or maybe she just has a very lean body mass. If women have a very lean body mass, they often have very irregular periods, and they may only have 2 or 3 per 24 months or 12 months. So, we have to look at all factors. And she could have some type of reproductive disorder going on. The fact that she did have her last menstrual period 3 days ago means that she is most likely not pregnant. That elevated temperature could be a variety of things. Maybe she is just wearing too many clothes or has too many covers on. In other words, dressed inappropriately for the weather or the environment. Maybe it is the environment. Uh, in the heat of summer, it can get pretty warm outside, and if we're not careful, we can easily become overheated. Sometimes just exertion can cause our body temperature to elevate, or maybe hypermetabolism. So, the most common thing that we think of would be infection or some type of a disease process. Unprotected sexual intercourse with two different partners. Well, we know that unprotected sexual intercourse can lead to pregnancy. It can also lead to the sexually transmitted infections. We do know that multiple partners can also increase the risk for some cancers, such as cervical cancer. Having that abdomen that's tender to touch. Well, most of the things that we discussed with the abdominal pain, it could be some of the same potential causes behind that, such as appendicitis or the bowel blockage or the gastroenteritis, etc. Maybe there was just an abdominal strain of some of those muscles, and that would definitely be tender to touch, or some other type of injury. That vaginal exam that shows the purulent exudate from the cervix, definitely sexually transmitted infection as a potential cause, but also some type of reproductive infection. So, what are potential complications of these things? Well, with the abdominal pain, peritonitis, we said that bowel obstruction could be a cause, but it could also be a potential complication or infection. Nausea without vomiting. If we have nausea, it makes or causes us to have anorexia. So we're not eating and potentially not drinking. So malnutrition is a definite potential complication, as is fluid volume deficit. No vaginal bleeding. Again, and I'm not going to really say that menopause is a complication. Some women think so, some women are just fine with it. And pregnancy. Again, some women are fine with being pregnant and other women are not. So a lot of it depends on the woman. The last menstrual period ending 3 days ago, really the only complication would be if she was wanting to be pregnant and she had a period, that means that she is not. The elevated temperature, infection, and that could always progress to sepsis if it's untreated or virulent enough. The unprotected sexual intercourse with two different partners. Again, STI, and some of those STIs can cause infertility. The abdomen that's tender to touch, peritonitis, and the vaginal exam that shows the purulent exudate. Again, infertility and potentially sepsis. So, what do we think is going on here? Well, my thought is this woman is having an infection and she definitely has that abdominal pain. So, what are our priorities? Most of the time I've told you throughout our courses together that pain is not a priority, but there are some instances where it is, depending on what could be causing it. And in this instance, we're going to say that pain is a priority in addition to the infection. So the expected outcomes, we would expect there to be minimal to no pain. We would expect her temperature to be within normal limits because we know that that is a specific sign of infection. And we would expect there to be no purulent exudate from the cervix. If those three things are met, then we can be pretty well assured that she probably no longer has an infection and we have met the outcomes. So we look at the members of the health team that might be involved in this woman's care. Well, I bet we're going to do some labs, so we definitely need some lab techs to provide some answers. What about pharmacy? Because I bet we're going to be administering some type of an antibiotic or some type of a medication to help take care of this infection. And analgesics, of course. We always, always, always know that the primary provider and the nurse and the CNA are going to be involved. If the nausea continues for too long, then we may need to incorporate dietary, potentially radiology. We may need to do some imaging studies of the abdomen if we are unable to determine where that infection is coming from. So, what should we avoid, or what might be contraindicated in the care of this woman? If she has appendicitis, we would minimize analgesics because we do not want to mask a potential appendix rupture. So we don't want to potentially cover up the symptoms we would see with a rupture by administering analgesics. So some of the things that we would definitely do, we need to monitor those vital signs. Remember, her heart rate was elevated, her blood pressure was elevated, and her temperature was elevated. We need to administer some analgesics, such as acetaminophen or NSAIDs, maybe some heat to the abdomen. That is definitely an intervention we would use for the abdominal pain. Do some imaging to rule out the appendicitis, and as I said, some lab work. We definitely need a basic CBC just to determine if there is an infectious process going on. We may need to go ahead and do a urinalysis and culture that exudate from the cervix. Since she's nauseated, we probably want to do some antiemetics, and we would want to initiate a broad spectrum antibiotic after we have obtained that culture from the exudate to cover a wide variety of pathogens that might be causing the infection. And then when we get the culture results back, if we need to alter the antibiotic, we can always do that. And one of the really important things is we need to educate the client on safe sexual practices. We cannot prevent how our clients are going to act sexually, but we can definitely educate them and hopefully maybe get some of our points across, such as wearing those male condoms to help prevent the transmission of STIs. So, priorities, I would say we need to get the blood work, the UA, and the culture going first. Then we need to um, probably go ahead and start the antibiotic and provide some pain relief with the analgesics and the heat and monitor vital signs. So, did our client meet those expected outcomes? Do we need to make any changes? Do we need to tweak what we're doing to improve the outcomes? So let's look at our priority client here. Is our priority client the client who is a postoperative hip repair reporting dizziness and extreme fatigue? The postoperative below the knee amputation client who reports phantom pain 9 out of 10? The client that has a cast to the right forearm with a report of edema and pink fingers? Or the client with a left ankle fracture requiring discharge education prior to being discharged in 30 minutes? Well, we look at number 3, for example. We do have edema. We know that could be concerning, but the fingers are pink. That means we have good circulation. So probably not number 3. We look at number 4. We have the client who does have a fracture, but they're going home. They're not necessarily going to be our priority client because remember, priority, if I don't take care of them, something serious could happen. So that leaves us with the client who has significant pain and the client reporting dizziness and fatigue, extreme fatigue. So we know phantom pain is a real thing that does need to be taken care of. But what could cause dizziness and extreme fatigue? Well, dizziness could be caused by low fluid volume, by hemorrhage, by a low blood pressure. And I don't know about you, but I think that all of those situations are a priority. So I'm going to go with number 1. Let's look at our 5 NCLEX style questions. We have a client who tells the nurse that he was diagnosed with BPH. Based on this diagnosis, which symptom is the client most likely to report? So what is this question asking? That's what you always need to determine first. In this case, what are the symptoms of BPH? A client tells the nurse that he was diagnosed with a BPH. What are the symptoms? Is it pain in the scrotum, trouble passing urine, erectile dysfunction, or constipation? Number 2 is the correct answer. Next question. The nurse sees that the client is taking tamsulosin. Which question would the nurse ask to determine if the medication is achieving the desired therapeutic effect? So what is this question asking? Basically, it's asking what outcome do we expect from this medication? Are you still having trouble passing urine? Does your urine have a strong odor or appear cloudy? Are you having any problems with achieving an erection? Have you had a green or yellow discharge from your penis? The correct answer is number 1, because BPH, remember, they have difficulty passing urine. So we definitely would expect them to have less difficulty passing urine. Next question. A 20-year-old woman is being evaluated for possible toxic shock syndrome. What question would the nurse ask? What is this question asking? Well, how about what are causes of toxic shock syndrome? Is it how many pads do you use on heavy flow days? Have you ever used intravaginal estrogen therapy? Do you have a history of multiple sexual partners? Do you use internal contraceptives? Well, again, you have to know what causes toxic shock syndrome. And to be perfectly honest, one of the main causes of toxic shock syndrome is going to be the insertion of items into the vagina that stay there for an extended period of time. The only one that fits that, the only ones that fit that are going to be number 2 and number 4. So intravaginal estrogen therapy, yes, the medication stays there. However, the applicator does not. The internal contraceptives, for example, the foam, the diaphragm, those have to stay in place for a certain amount of time after intercourse to allow the spermicide to work appropriately. So they are a potential cause of toxic shock syndrome. Number 4. Last question. Which woman is at greatest risk for pelvic organ prolapse? What is this question asking? What causes pelvic organ prolapse? Is it a 16-year-old adolescent caring for her first child? A 25-year-old who became sexually active at age 15? A 34-year-old who has a history of endometriosis? Or a 48-year-old obese mother of 4 children? Remember, childbirth is one of the major causes of the weakening of those pelvic muscles. That would leave us with number 1 and number 4. Multiple children increases that risk, as does obesity. The correct answer, number 4.